Hello, and welcome to the Sarah Clinical Education's Oncology Podcast. I'm your host, Kemi Abajini. Today's episode features expert perspectives on new and emerging targeted therapies for patients with diffuse large B-cell lymphoma. This episode is part of a larger educational program titled Optimizing DLBCL Treatment, an expert roundtable on the role of new and emerging targeted therapies. This podcast features Dr. Gilles Salles, Service Chief, Lymphoma Service, and Stephen Greenberg Chair at the Memorial Sloan Kettering Cancer Center, Weill, Cornell University in New York, and Dr. Pier Luigi Zinzani, Professor of Hematology and Head of the Institute of Hematology, Bologna University School of Medicine in Bologna, Italy. They will be providing an overview of the unmet needs with current standards of care in the management of DLBCL in Europe versus the United States, and discussing the expanding role of novel agents in DLBCL, access to targeted therapies, and clinical trials in non-academic DLBCL practice, and key ongoing trials of new and emerging novel agents in DLBCL. They will also be providing highlights of key studies in DLBCL presented at the 2026 European Hematology Association Congress. For more information on Dr. Salles and Dr. Zinzani, along with a link to the complete program, please visit the show notes for this episode. Now let's get started and hear what the experts have to say on this important topic.
Hello, welcome to this podcast. My name is Gilles Salles. I am the Lymphoma Service Chief at Memorial Sloan Kettering Cancer Center, affiliated with Weill Cornell University, and joined by my colleague.
I am Pier Luigi Zinzani, full professor of hematology. I am the director of the Institute of Hematology Seràgnoli in the University of Bologna, Italy.
So today we are going to discuss this topic, which is important and really changing rapidly regarding these therapies in diffuse large B-cell lymphoma, a highly curable disease, but unfortunately not all patients are cured. And for these reasons, we need to have these new agents and know better how to use them. We will first discuss the overview of the unmet needs. Then we will discuss the expanding role of novel agents and how these targeted therapies are available for patients, how they can access within clinical trials, how it's the access in academic and non-academic centers. And we will also emphasize the potential differences existing between patients living in different areas of the world, particularly in Europe and the United States. We will discuss a couple of ongoing trials and novel agents that are being currently investigated and what we may expect from them, and also discuss what was presented recently either at the ASCO 2026 or EHA 2026 meeting in terms of trials regarding DLBCL, and then we will conclude. I think we have understood that there are a couple of unmet needs. I will say we can classify the questions currently at what is the workup at diagnosis? Are there any differences? We have been adopting different lymphoma classification. There have been, unfortunately, a few years ago, different input by different groups of colleagues, which are being reunified right now. FISH has been implemented now since probably 1 decade in helping to identify those cases with double hit. And now we are moving towards delineation of some entities using molecular profiling. Obviously, with imaging, we use PET scan and we use classical prognostic index. Pier Luigi, anything specific you would like to add regarding the initial workup, what we are missing at the present time, what will be the tools that we would like to see in our practice coming up?
As you said before, in terms of histological classification, we are using the same that you are using in the United States. And also in terms of what to do in terms of staging before treatment. One point is quite important that I think is a little bit different so far when you compare Europe and the United States is the role of MRD and ctDNA. Because I think could be important in the clinical trial, but so far in Europe in particular, or in the real life outside the clinical trial, we don't use.
You touched an important point, which is evaluating patient response. I think worldwide, the use of Lugano classification for evaluating the end of treatment PET has been used, but we do know that some patients who present with a negative PET-CT are still exposed to a risk of relapse, while sometimes we have difficulties in interpreting some result with PET on the Lugano scale being, and the Deauville scale being either 4 or 5, and with minimal lesions, and whether we want to use radiation, whether we want to use a biopsy,
And so on. Yeah, but I think another important point that could be different between the two continents is how to follow the patients after the first complete metabolic response after the induction treatment. Normally, in our institution, as in several other European institutions, we use the PET evaluation for the first at least 2 years. Every 6 months, and then we move from the 3rd year to the 5th year with a PET every years. But I know that is a real heterogeneous field concerning this issue in the setting of, I think, United States, but also in the European countries.
If the patient has reached a complete response, usually the recommendation is to use CT only for every 6 months for 2 years and interrupt after 2 years. There have been some discussions, but even not to imaging patient, but most of us will image patient every 6 months. If there is any equivocal data on the final PET, they will use potentially another PET or 2, but try to move quickly to the CT. I think you mentioned the role of MRD and ctDNA. ctDNA has been a new tool. It has been developed, and there have been now several reports indicating that it will be highly discriminant to identify patients with a high probability of cure, probably above 90%, versus those who have a high risk of disease recurrence in the 20 to 40%, depending on the technologies and things like that. I think all this data came from mostly studies performed with either companies developing these tools or potentially some academic labs. We have seen that in the UK, in the Nordic countries. How do you see this field evolving in the near future, Pier Luigi?
Could be important, could be interesting to combine with a PET evaluation to really understand the response or the potential risk of progression of the disease. But at the end of the day, right now, there is no a real perfect method that we can use in this situation. And outside some clinical trial or the potential support from some company could be difficult in terms of economic point of view to use this kind of evaluation.
The field will be moving a little bit faster here, given the fact that 1 or 2 of these companies are approaching very quickly FDA and may have their test being approved in the near future, and this might change. We discuss here the diagnosis, the initial response. Obviously, we have major concern for those few patients, 5-10% who have early refractory disease, and we will see how we manage the relapsing patients, the patients that experience disease recurrence in the near future.
This is a very important point because we can obtain, in the most part of the patient, a complete metabolic response during the induction treatment in front line. But of course, the real problem is to identify as soon as possible the potential patients considered refractory or the early relapse. But now, if you compare with the last 5 or 10 years, we have a very important therapeutical option also for these patients. In particular, the CAR-T second line, this could be another important point. The control of the response during the frontline treatment. In particular, the interim evaluation with PET and or CT scan after 3 or 4 cycles of the induction treatment could be very useful to really understand if there is no response or a very short or very small response, why not to move directly or to CAR-T second line, or to evaluate very strictly this patient with a final evaluation after the frontline treatment, after the 6th cycle, not after 1 month, 1 or 2 months later, but after 2-3 weeks to really understand if the patient obtain a final complete metabolic response. This is fundamental to stratify as soon as possible the potential patient for the second line, and in particular, of course, for CAR-T or for a good chemo-free regimen in second line with a good alternative in terms of treatment.
Yes, we are in perfect alignment on this topic. So let's maybe dive a little bit towards these new agents, and I hand it to you, Pier Luigi, to introduce this topic.
We are really in a new era concerning new agent in the setting of diffuse B-cell lymphoma. Right now, the therapeutic algorithm of this disease is incredible. It's quite close to the multiple myeloma Sudoku in terms of new agent, and could be sometimes quite difficult to decide what to do in terms of vision when you start the treatment of diffuse B-cell lymphoma. The very long list of novel targets and agents according to monoclonal antibodies, CAR-T cell with 3 different products, all of them CD19, and all the bispecific, and the most part, of course, CD20, CD3, but now we have also a new CD19, CD3 that could be very important in terms of some alternative targets and the surrovatamig. And of course, the list of the antibody-drug conjugates, loncastuximab-tesirine, polatuzumab, vedotin, brentuximab, and also zilovertamab. And all the intracellular agents such as BTK inhibitors, the cell mode of third generation, golcadomide, BCL6 degraders, TARIC4 inhibitors, and the other targets, CD22, ROR1, CD37, and also the CD70 with some new potential bispecific, and as I said before, of course, CD20, CD19, and CD3. And I think it's important at this point to stress if there are some difference between Europe and the United States. And for example, what is the current role of BTK inhibitors, for example, another important issue concerning the potential role in the setting of relapsed refractory diffuse B-cell lymphoma, why not in the future also in front line?
At the present time, none of these drugs had received a formal approval for patients with diffuse large B-cell lymphoma in any line of therapy. Although we do know that there are specific subset of DLBCL that may have an elective sensitivity to this drug. So after the result of the Phoenix study in the first line study, there have been other studies using acalabrutinib, which is accompanied with less toxicities and probably more manageable in combination with chemo. So we are awaiting the result of the randomized study called Escalade, combining rituximab CHOP versus rituximab CHOP plus acalabrutinib. It's a double-blind study, so this will be very important. I will say that sometimes in the relapse setting, we might have access to use of these drugs if insurance approve it, either alone or in combination with lenalidomide. Minor response, but in not heavily pretreated patient, you may see some transient response in maybe 1/3 of the patient, and this remains sometimes useful to bridge for another form of therapy.
Yeah, I agree with you that the potential role of escalate, if the trial will be positive, will change finally the concept that we can use in frontline in combination with conventional chemotherapy or second generation BTK inhibitors, such as acalabrutinib, because it's less toxic, or ibrutinib, and there was a difference in terms of inclusion-exclusion criteria when you compare with the Phoenix, because Phoenix included patients until 80 years old, and in this case, for escalate, they reduce at the beginning to 60, and then in the last 6 months, they put check in terms of age at 75. Surovatamig. So as I said before, surovatamig, CD19, CD3 bispecific, I think could be very important. Of course, there are several ongoing phase 1, phase 2 study, not only in diffuse B-cell lymphoma, but also in follicular lymphoma. And what is your opinion in the United States concerning the potential pivotal role of this new target in the setting of the list of bispecific monoclonal antibodies?
In the United States, bispecific have taken place, probably more in academic center and in large community centers than in small community practice, given the management of this drug. And CD3 to CD20 antibodies, whether they are used alone or in combination, start to be routinely used. Unfortunately, this is not sufficient, and having a new one with a new target is important. And we are also awaiting the time where potentially the CD3, CD20 will be entering first line of therapy, and then having at our disposition a CD19, CD3 will be very important. We are waiting the phase 2 and the registration of this drug, and I think it will take another 1 to 2 years. So the results we have seen are very promising in terms of CR rate and in terms of duration of CR, but more to come with final results and evaluation by health authorities.
Yeah, I agree with you. The same situation is in Europe because academic center, but also the major hospital with the institution of the pathway hematology, they are using bispecific CD20, CD3 in third line according to the official indication, and sometimes they prefer to use bispecific instead of CAR-T. This is another important point that I know is quite similar to this problem also in the United States. But of course, with the potential future where the CD20, CD3 will be included in front line, and there is a risk of CD20 loss, could be important to have another target such as CD19. Antibody drug conjugated, I think there are some difference when you compare the United States versus Europe in terms of do you use polatuzumab in front line in the setting of patients with diffuse B-cell lymphoma according to the Polaris study?
Well, it's used in about 35 to 40% of the patients newly diagnosed. And I think some centers will restrict the use of patients with what they will call non-GCB based on immunohistochemistry, where other centers will use it according to the market approval. So it's more philosophies that clinicians will take.
On the contrary, in Italy, the use of polar chip in frontline is close to 65%. And some hematologists prefer to use this in the elderly patient according to the registration study, according to the API, 3 or more than 3, according to the site of origin. But at the end of the day, at least 60% of the patients are using polar chip in frontline. Back to the CAR-T issue, we discussed it a little bit before, but I think the situation is quite similar to the United States. In Europe, we have several programs to use CAR-T to receive as a CAR-T center patient from the referral center in third line, But sometimes you have several problems also in second line because they prefer to use the classic conventional chemoimmunotherapy salvage treatment plus auto stem cell transplant to avoid to lose the patients, to maintain their local visibility. No more than 35-40% of the patients eligible for CAR-T move to the CAR-T center.
We do know that in the United States, the size of the country, the insurance, the costs, the different buyers exist, and the penetration of the number of patients candidates that receive CAR-T is probably about 20%. So I don't think this will be moving dramatically in the near future. And as you said before, antibody-drug conjugate and bispecific antibody T-cell engager are making inroads into this area. We will see. I think it's still an area where it had become a little bit easier with some regulatory change regarding proximity from the treatment center, with the availability of products that are efficient and well tolerated. Recently, the US consortium reported 1,000 patients treated with liso-cel and with quite good result. But at the end of the day, CAR-T only cure 1 out of 2 patients, whether in second or third line. So there is still a lot of space to improve upon that.
Sure. The last 2 points, we can put together the potential role of cell modes, in particular, of course, the third generation of golcadomide, and also the BCL6 degraders. There are several clinical trials concerning the role of these 2 new agents that could be a very important new potential targets for our patients with diffuse B-cell lymphoma. What do you think, which is the role right now in the United States?
No, I think there is no difference. Maybe there are a little bit more investigator-initiated studies being run out, but we need to see more data to discuss what's the potential of this patient in the near future.
Yeah, there are some preliminary interesting data with Golca, of course, in diffuse, but also in follicular lymphoma. We are only at the beginning of the story concerning the potential role of BCL6 degraders. Also, in our institution, we have 2 phase 1 studies at this moment, but could be another good opportunity, we hope, in the future for our patients.
If we move to the ongoing trials in DLBCL, I think what we are expecting in the relapse setting are a few publications regarding data that were presented, for instance, at EHA. We'll touch upon that later. We heard about the role of oncastuximab, randomized trial, epcoritamab, but more importantly, we just heard also recently about epcoritamab and lenalidomide, and as we said, surovatamig. I think what is making us a little bit in a situation which is exceptional is the fact that there are probably 8 or 9 trials in the first line setting. So the first one was a frontline trial, which results have been presented and published with tafasitamab. Then the bispecific antibody, there are 3 clinical trials with epcoritamab, glofitamab, and with odronextamab that are being run in the frontline setting. We discussed already the ESCALATE trial with acalabrutinib. And in addition to those, there is golcadomide being investigated in a phase 3 trial, which I think has completed accrual, and as well as ZUMA-23, which is assessing the role of early intervention with CAR-T in patients with very high risk. I may forget some, but I think this is probably the major the major landscape, and there are differences in the trials, and most of them use R-CHOP as a control arm, except the trial with glofitamab, which uses polar-R-CHP as a control arm and as a backbone to which glofitamab is added. I should also mention that there is at least one trial that assesses the role of an allogeneic CAR-T in patients that are MRD positive at the end of treatment, but there are a few projects either with bispecific or with other CAR-Ts to be done in this setting. So at the end of the day, maybe Pier Luigi, we can predict the result of these trials, but what will be, do you think, the key elements in a nutshell of how we are going to interpret those, and what will be potentially the key decision factors whether to use this new agent versus that new agent versus another new agent?
Now, this is a very important question, because except Escalade and also the ZUMA-23, for the all other 7, 8 ongoing phase 3 study, the inclusion and exclusion criteria are the same in terms of age, from 18 to 80, and in terms of IPI from 2 to 5. And this could be a problem at the end of the day when we hope probably that most of them will be positive. And how is possible to stratify the use of this different trial in our setting of patients with diffuse B-cell lymphoma? And could be easier in the United States, the role of the drug agency, but I don't know in Europe, EMA. Do you think EMA will upset all these different trials in the same setting of patients where most of them are quite similar? I mean, R-CHOP plus bispecific in at least 5 or 6 of them. This could be a very important point for the future, because except Escalade and ZUMA-23, where they have a different study population, for all the other, the study population, including the trial, are the same.
This is a very important point, but as we know, usually drug companies make commitments with the agency, and this commitment has to be fulfilled as long as the results fulfill the expectation. My point of view is that both agencies, but also the reimbursement in Europe in different countries, as well as the guidelines in the US and potentially some insurances, will look at the side effect profile of these different drugs and the constraints. We already had this discussion with tafasitamab and R-CHOP, where patients had to come every week to receive the infusion of this CD19 antibody. So that's a constraint, and this was associated with lenalidomide and R-CHOP with a significant heme toxicity. It's a positive trial, it's improved PFS, but the burden for patient and the toxicity are here. So I think we'll have to balance that when this result come. R-CHOP has been easy. It's patients were coming every 6 weeks. For R-CHP is the same. Patients are coming every 6 weeks. But now, one of my colleagues said there is not only constraint for the patient, but also for the clinical team, seeing the patient every week and having to evaluate the counts, the cell counts, the side effect, a little bit of fever, what to do with that. That's a lot of constraints. So
that is another logistic problem, yes, of course.
So I hope for patients that some of these trials will really show benefit, and maybe, looking at some subgroup biologically or defined differently will be guiding us on what to use. But I think it's a complex area.
Yeah, could be more difficult, and you have to know very well all these trials, all this data, and to have a very important vision when you start with the treatment in front line, with, as you said at the beginning, to decide what to do in front line and to be sure that you have a good opportunity of treatment potentially in second line with a different target if there are some CD20 loss, for example.
And I should mention that the trial combining surovatimig with R-CHOP is just on the initial steps of implementation at several centers, and will attract also a lot of investigators. I was fairly impressed to see that many of these trials have accrued patients in 1 year and a half, 18 months to 2 years, even 500, 600, 800 patients. The field is moving very quickly. So these are good opportunities for patients. And, surovatimig has this particularity of targeting CD19, while we are targeting CD20 with rituximab. Yeah. So the question of antigen escape is probably less an issue with this drug. But again, we have to see the results.
Now we move to the key presentation result of the last AHA meeting in Stockholm, and which presentations at this meeting were particularly interested in practice changing. And I think there are some interesting presentation. Of course, as you said before, Gilles, there was at EHA, but also at ASCO, the final presentation of the front-mind trial by Georg Lenz. Was the first new phase 3 trial in frontline, the setting of advanced diffuse B-cell lymphoma. There was a very interesting presentation also by Dr. Bousami concerning the role in frontline of Polar CHIP plus golcadomide. And preliminary result, because they included 58 patients, all untreated patients, advanced disease, IPI 3 to 5. And there was a randomized study concerning the comparison between different doses of Golca, 0.2 milligram versus 0.4 milligram. And at the end of the day, preliminary result, of course, evaluable no more than 28 patients, but was incredible, the result when you use 0.4 milligram in terms of complete metabolic response, roughly to 90%. Independently by the high-risk patient, on the basis of the IPI or the presence of a bulky disease, also according to the CO. I think this is a very important point for the future. Okay, we have a very short follow-up, no more than 16 months, few patients, but the inclusion in frontline of this third generation of lenalidomide could be very, very interesting, because at the same time, the safety profile is very good. What do you think about this preliminary data, Aziz?
Yeah, I think, as you said, they are preliminary, and I try to bring things in perspective. You know, when we have seen the results of bispecific as single agent 3-4 years ago, we said, wow, fantastic. In the relapse setting, we get this 40% response rate and this CR rate, and they're relatively stable. This was true also for combination with GEMOX, with polatuzumab, with other agents. I kept saying, well, these results are early, and we don't know whether this will really cure patients. So one of the presentations at AHA was the long-term result of patients receiving glofitamab single agent. And it shows that overall, it's about 50% of the patients receiving the active dose and reaching a CR, not all patients entering the trial, but those that reach a CR who had a maintained complete remission up to 5 years. And clearly after 2 years, 24 to 36 months, the curves look pretty flat, showing that a patient do not relapse. We have seen emergent result with rheumatic and others. And the question to me, which is also related to the question you asked regarding this combination trial, is that the complete metabolic response is an important endpoint, but we would like more and more to see the evaluation of ctDNA in these first-line trials, and looking at that with the appropriate technologies, given that we have learned now the appropriate technologies using different nucleotides close by, but it can be different approaches, and are really the most sensitive. So I think looking at this phase 2 data is very exciting, and we have already seen R-CHOP EPCO with 100% overall response rate. We have seen the polatuzumab, R-CHOP, LCHP, and Glofit 95% PFS at 1 year. But now I think we will like, before the randomized trial, and even when the randomized trial will be presented, paying interest to this new data on ctDNA. And we do know that in this clinical trial, this will be collected and probably presented.
Yeah, but I totally agree with you concerning the fantastic data at 5 years of Glof in the setting of a relapsed refractory patient with diffuse B-cell lymphoma from the third line, because these data right now with this long follow-up are quite close to the data of CAR-T in third line. And this is a very important point. I mean, bispecific fixed duration, for example, with Glofi, you can obtain the same result in terms of curative treatment at 5 years when you compare with CAR-T. In terms of, potential toxicity, question mark, but in terms also of cost, could be a difference. It's a very important point. And for this reason, there are several new combination, new regimen, including bispecific plus, for example, ADC, monoclonal antibody, moving from the third line to the second line. And these preliminary data, such as, for example, LOTIS-7, Glofi plus long-castuximetaserin, the preliminary result in the phase 2 study are really impressive because the CR rate is 85%. We need the evaluation of the response. You need, as you said before, why not the evaluation of the ctDNA in this patient? But there is a new kind of regimens in second line, the setting diffuse B-cell lymphoma, all chemo-free, with this concept of bispecific plus other monoclonal antibody, in particular ADC monoclonal antibody. And this could be in the future also a big competitor with the CAR-T in the same setting of second line.
Yeah, I'm fully aligned with your statement. We are getting close to the end of this podcast, and I would like you, Pier Luigi, to give what you feel is the most exciting concept, most exciting drugs in the setting of new and emerging therapies for DLBCL.
Surovatamig could be very interesting because they're new targets. The concept of to combine chemo-free regimen in second line, like I said, LOTIS-7, Glofi plus long-castuximetaserin. I think about the very long list in front line, ZUMA-23. ZUMA-23 because on the basis of the phase 2 study, the ZUMA-18 was where the data were really incredible for high-risk patients. IPI 4 and 5, that this setting of patient represent the patient with early relapse or refractory to the frontline treatment that normally are resistant also to or refractory to the second line with CAR-T.
Yes, thank you. I share obviously the enthusiasm for all these studies. I will add to that the targeted therapies, oral agents such as BTK inhibitor, including acalabrutinib, but also CELMoDs or BCL6 inhibitor, are new family of drugs which can be combined with some of the active agent, may have the potential to improve the efficacy of bispecific. As we said, we do know that these bispecific T-cell engager are curative, and this is an important message in the last year, alone or in combination. We do know that investigators and companies are moving extremely fast with the field of providing the manipulation of T-cell in vivo. This was one of the late-breaking abstracts for EHA, where a few patients were receiving what is called in vivo CAR-T, basically the ability to transduce T-cell in vivo. And we do know that this could be also transformative therapy.
Thank you very much, Dr. Salles and Dr. Zinzani, and thanks to you, the listeners, for joining us. As a reminder, to view the full program on optimizing DLBCL treatment, an expert roundtable on the role of new and emerging targeted therapies on the DESERA Clinical Education's website, please click on the link in the show notes. As always, thank you for listening.